respected dignitaries on and off the dais, my dear friends and colleagues. First of all, let me thank the organizers for allowing me to present this topic in front of this august audience. As we all know that humerus fractures are quite common. It represents around 5% of all fractures. And around 17%, some literature say up to 22% develop radial nerve palsy in shaft of humerus fractures. And it is usually a neuropraxia, but there are some cases where you need your intervention. Why radial nerve palsy is common in humerus shaft fractures? Because of the peculiar anatomy. We know that radial nerve extends from the pectoralis major up to the elbow joint area, and the fibers of the medial end of triceps and the brachialis protects radial nerve from the cortex. But as the radial nerve comes down, it pierces the intramuscular septum and it acts as a tether, and that tether results in radial nerve palsy. So there is an area where radial nerve is less mobile, especially toward the lower third. So the force of injury causes the proximal fragment to move distally and thereby displacing the lateral intermuscular septum where the nerve gets tethered. So there are several classifications for radial nerve palsy and humerus fractures. It could be a partial one, it could be a complete one, and it could be a condition where there is neuropraxia, neurotomesis or axonotomesis. And sometimes after surgery, the patient develops radial nerve palsy. It is important to document in the preoperative diagnosis itself whether there is radial nerve palsy or not. Otherwise, after reduction, you may not know whether your reduction has resulted in a radial nerve palsy. So, iatrogeny could be in a closed reduction or a closed reduction interval fixation or open reduction interval fixation. In intramedullary nailing, the literature says the iatrogenic injury is around 5%, and in plating it is around 10%. But most of them may be neuropraxia. Some studies tells routine exploration of the radial nerve if there is radial nerve palsy preoperatively. Now this has value in follow-up, not in the primary settings, the EMG and the NCS. And this will tell you at 6 weeks whether there is any recovery or not. So in the primary setting of an acute fracture of the humerus shaft with radial nerve palsy, there is no role for a EMG or a nerve conduction study. So the radial nerve enters the anterior compartment around 10 cm proximal to the elbow joint, and in the lower third fractures, the Lewis fracture or the Holston-Lewis fracture, there is always a risk of radial nerve palsy. Sometimes it comes after reduction. Preoperatively there may not be any radial nerve palsy. Once you put the slab or try to manipulate, it results in a radial nerve palsy. It is sometimes described as a Holston-Lewis syndrome. So you have to check for the radial nerve palsy in every case you examine, and then you have to document it. And the issue comes when it is a post reduction or a post surgery. Then the issue is little different. So the primary radial nerve palsy occurs from injury with increased incidence in the distal third. This is what is Holston-Lewis fracture is. And in open fracture, there could be a laceration or a neurotomesis. So open fracture is one condition where when there is a radial nerve palsy, you have to explore immediately. Another indication is after an iatrogenic injury, you have to explore it. But if you have a patient with a isolated radial nerve palsy in a shaft of humerus fractures, you need not explore it always. Around 80 to 85% recovers over time. So if the fracture is closed and there is complete radial nerve palsy, the treatment is a slab or a splint, and then you look for recovery. Most of the time it recovers. Now, if the radial nerve does not recover over a long time, for example at 3 months, then there is a role for 6 weeks to 3 months, there is a role for EMG, NCS and exploration. So 85% of the patients show improvement in 3 to 4 months and full recovery at 6 months. This is a usual outcome of a radial nerve palsy. And you have to look for the finger drop, wrist drop, thumb drop, and if you want to avoid the gravity and test for it, you can do like this. If it is like this, it is against gravity. You do like this, it is by negating the gravity. The first muscle to recover is brachioradialis. And you have to monitor the brachioradialis for the first early recovery. And the last to recover is extensor indicis, because it is a far away muscle which is innervated by the radial nerve. So the first recovery is brachioradialis and last recovery is extensor indicis. So the measure the distance from the fracture to the brachioradialis, which is the first one to recover. And wrist extension with radial deviation occurs usually when recovery occurs, because extensor carpi radialis is the first muscle to recover compared to extensor carpi ulnaris. So first it goes radialwards, but after some time when both muscles recovers, you get the same type of dorsiflexion. So when there is a radial deviation, you need not worry. After some time, it will get corrected. Now there is no sign of recovery, or if you feel that this nerve will never recover, or if the person wants to go to job very early, then you can think about a tendon transfer. So the easiest and the commonest is a modified Jones procedure, where you take pronator teres, give to extensor carpi radialis brevis. You take flexor carpi ulnaris, give to extensor digitorum, and take palmaris longus to the extensor pollicis longus. It's a very simple surgery. Anybody can do that with some training, and there is no need of a huge plastic surgery or a hand surgery person to help you. So it's a very simple surgery. Now the advantage of this is that immediately or within 6 weeks, patient can go back to his work. And suppose there is a situation where you repaired the radial nerve and you did tendon transfer. Patient got recovery at 6 weeks. If the radial nerve recovers after that, what will happen? Anybody from the audience? You have done a tendon transfer, you have done a radial nerve repair also, or you have waited for radial nerve recovery. So a situation comes where your tendon transfer has worked properly. The radial nerve also recovered. What will happen? Anybody from the audience? Yeah, nothing will happen. So if you want the patient to go back to work, there is no harm in doing a tendon transfer. Patient can go back to work soon. So this happens, this is usually done by plastic surgeons. There was a recent case, it was operated by one surgeon in Telcheri. I am not naming the person. The patient developed radial nerve palsy following an intramedullary nailing. And then there was wrist drop, everything. They went to a plastic surgeon somewhere near Cochin. They did immediate radial nerve exploration and did tendon transfer. So 3-4 months patient was like this with the wrist drop. Within 1 month patient started working. So the patient thought that it is a magnanimous work. He immediately went to court, and Consumer Protection Court slashed the surgeon with some lakhs of rupees. This has happened around 3-4 months back. So this will happen. So we surgeons should be equipped with the technique of tendon transfer. It is not very difficult. So what do you transfer? This is what I already described you. These are the muscles which can be transferred. It's a very simple technique. So this you should know. Now you look at the literature. Now if you look at the literature, neuropraxia is the most common type of nerve injury, and transection is only 12%, and tendon transfer usually needed only in 7% of cases, and nerve grafts are sometimes needed, but especially in open injury where there is a nerve loss. Usually a nerve graft is not needed. Now radial nerve exploration, if recovery is delayed more than 12 weeks, it's okay, you can do an exploration, a closed fracture, provided it is not a open fracture or a iatrogenic injury. So recovery is delayed sometimes up to 4 to 5 months. And these are the tricky situations where you think that you created a radial nerve palsy, then you have the obligation of exploring it. So this is what is from the literature. Around 22% has got radial nerve palsy, and some people say around 11.2%. This is due to the fixed position of the radial nerve, which I already described because of the tether effect. Now, what is happening at the groove? Usually, the incidence in the groove is less when compared to the lower third shaft of the humerus, because in the groove there are at least some muscles to protect it, but on the lateral side, the nerve is on the cortex. So that is why Holston-Lewis type of fractures result in more radial nerve palsy than the groove fractures. And polytrauma is one indication where you have a floating elbow. Even if there is a radial nerve palsy, you will fix it. Once you fix it, you have to explore the radial nerve also. So bilateral humerus fractures and vascular injury, these are the other indications for early exploration. So in every case of radial nerve palsy, you need not explore the radial nerve. Surgery means some patients who are not able to wait for long, you can always explore it. Early activity is demanded, you can do that. Late onset radial nerve palsy, initially no radial nerve palsy, then radial nerve palsy comes in, you can do exploration. And for non-union, If you are looking for grafting, you can explore, and loss of reduction. These are the indications for exploring the radial nerve in primary settings. So this is one which I have already described. So advantage of early exploration is that early characterization, you know what has happened, whether it's laceration or a discontinuity of the nerve, then you will understand if you explore it early. Stabilization and better rehab is possible if you open early and fix it and explore it. Less muscle loss and loss of motor end plates, because motor end plates survives only up to 9 months. After 9 months, you will not get motor end plates recovery. So if after 9 months, even if the nerve recovers, the neuromuscular junction will not function. So everything has to happen within 6 months, because you need another 3 months for the nerve to grow to reach the motor end plate. So beyond 6 months, you should never wait for any of the radial nerve exploration if you want the radial nerve to recover. So neurography of excising the fibrous tissue, nerve grafting, and length of the grafted tissue decides the outcome. There is a loss of nerve, then the length of the lost area decides the final outcome. So when there is a fracture, the anatomy becomes distorted, and because of the fracture, so different methods are available for treatment, the posterior approach or the anterolateral approach. Some studies tells us that you wait and see, in any case it will recover, but there are some studies which tells us that you have to explore early. So this is about a Holston-Lewis fracture. You can go for this is a radial nerve which is on the plate. So if you do the plating by posterior approach, the area where the nerve crosses, please don't put any screws there, because the screw head may hitch against the radial nerve. So you put the screws above and below the area where the radial nerve crosses. Try to avoid the screw hole area where the nerve crosses. You can go for double plating or a single plating, whatever plating you do, but don't put screws the area where the radial nerve crosses. So to conclude my presentation, treatment of humeral fractures with radial nerve palsy could be complete or partial. It could be a primary one, a late onset one, or an iatrogenic one. Observation during recovery is a good idea of treatment, but you have to mobilize the joints. See that the joints are well protected. Prevent the joints from going from contracture, which can be done by physiotherapy or extensor splint, the dynamic splint, the cock-up splint, anything you can use that. But see that the joints are supple till the nerve recovers. If the fingers are contracted and the nerve recovers, then it is of no use. So see that the joints are supple till the nerve recovers. So dynamic splitting is very important. So early exploration and late exploration is a controversy, but most of the cases recover within 4 to 5 months time, but never wait beyond that. I take this opportunity to invite you to Arthrocon 2024. Thank you for patiently listening.